Hello and welcome to this Orygen, the National Centre of Excellence in Youth Mental Health webinar on complex presentations, engagement and assessment. My name is Shona Francie and I'm the moderator today. I'm a clinical psychologist working at Orygen, the National Centre of Excellence in Youth Mental Health. Before we get started, I'd like to make an acknowledgement of country. I'd like to acknowledge the traditional owners of the land on which we're meeting today. I'd also like to pay my respects to their elders, past and present. So just a few housekeeping things before we get underway with the webinar. Today's webinar will be recorded and it will be available a little bit after the webinar is finished via the website. So the address is on the screen. If you go to that address, the campus page, you'll see the circled orange square. That's the webinar button. If you click on there, that's where you'll find this webinar if you want to review it, or if you've got some colleagues who weren't able to join us today who would like to see the webinar. And we're able to take questions from the audience of this webinar today. Mostly we'll try to answer those at the end of the webinar, but do send your questions in through the webinar and we may address them as we go through as well. So to send us a question, you type the question in where the arrow indicates in the little panel that's on the right of your screen. So if you type into that box there and then press send, we'll get that question and attempt to answer them at the end of the webinar. Okay, so now it's my privilege to introduce our presenter today. There is only one presenter today, which is Heather Staveley. Unfortunately, Caroline Serlignac, who was going to join Heather, is unavailable at the last minute, but we're very grateful that we've got Heather here to speak with us. Heather is a senior social worker. She's the Associate Director of Service Development here at Orygen. Heather has extensive clinical and service development experience. She has worked closely with Headspace National to create the early psychosis services across Australia. She's been responsible for the program management of several large national projects with a focus on upskilling the youth mental health workforce and service development activities. And Heather's presented internationally at conferences and many forums and has a lot of experience in working in youth mental health. So I'm going to hand over now to Heather and I'll come back at the end of the webinar. And Heather, I think, is going to start by giving the learning objectives for today's webinar, which is on complex presentations, engagement and assessment.
Thank you, Shona, and welcome to everyone. It's lovely to be here today and to look at this particular topic. So yes, these are our learning objectives that I hope we can get through today. So I won't read all of those out, but it's really, to give you a bit of an overview, to look at some of the principles behind a sort of biopsychosocial assessment. And also towards the end, we'll also be aiming to illustrate some of what we have presented through some clinical examples today as well. So look, this is really just to get you thinking. This is Abdul, and this was some initial referral information which you can read there for yourself. And I suppose it's just really sort of, bring up a question like, what is complexity? If you think about Abdul here and looking at that sort of pretty brief information you have, it could be that there's diagnostically a range of symptoms. He could have PTSD, so post-traumatic stress disorder. He could be at ultra-high risk of becoming psychotic or getting unwell. Could be first episode psychosis, and he would have some comorbidities such as substance use. There might be some personality traits or issues there, but also it could be very reality based as well. He also has other issues that relate to vocational, financial, future goals and family isolation. So I'm just wanting you to think about, is this the sort of person or young person that is complex? So here's another example, and we will be coming back to this particular young person, James, later in the webinar today. So again, you know, is this complexity? So, you know, what do you think as a clinician when you read a history of these diagnoses, and this is before you've even met the young person or the family and heard about the struggles they're all facing? As you can see there, it is quite a very long list of diagnoses, or sort of, you know, particular comments. Okay, so as I said, we'll come back to this, but let's have a look at complexity in more detail now. So comorbidity or multi-comorbidity does bring some extra complexity. In the sort of 2007 National Survey of Mental Health and Wellbeing, it describes comorbidity as the co-occurrence of more than one disease and or disorder in an individual. So mental disorders may co-occur for a variety of reasons, and particularly, say, substance use disorders frequently co-occur. So a person with co-occurring diseases or disorders is likely to experience more severe and chronic medical, social and emotional problems than if they had a single disorder. People with comorbid conditions are also more vulnerable to alcohol and drug relapses and relapses of mental health problems. So higher numbers of disorders are often associated with greater impairment, higher risk of suicidal behaviour and greater use of health services. So the question for us is, how do you assess and engage when you have complex presentations? So today we'll be looking at this, particularly for young people. So as I said, let's step back and think about complexity, assessment and engagement and what they mean. It's interesting that the Victorian Government in 2012, when reviewing families with multiple and complex needs and trying to answer, you know, the question of really what are they, suggested the following terms that are used across professions to define complex needs. Things such as multiple disadvantage, disabilities, adversities, impairments, dual diagnosis, we've heard that one often, high support needs and complex health needs. They go on to say that a definition of multiple and complex needs implies both, and you can see that on the screen there, breadth of need and depth of need. And I think it's really important that people remember those two ideas or those two concepts when thinking about complexity. So rather than use the term multiple and complex needs to describe a person's characteristics, it's more helpful to use it to describe the array of problems confronting a person that frequently span the areas of social, economic and health issues, and as a framework for understanding and response. So people with complex needs may have to negotiate several issues in their lives, such as physical or mental illness, substance use and disability. It is important to remember these points. And also just to remember too that, you know, having a mental health episode or illness, you know, that is very complex, brings complexity itself to a young person particularly. Even within the juvenile justice system, you know, it's been noted at times that many adolescents involved in that system represent a higher risk and clinically complex group of youth with overlapping risk factors and comorbidities that really extend beyond just, or not just, but delinquency and so conduct disordered behaviour. Within that system, many youth, as I'm sure a lot of you will be aware, present with psychosocial histories that include high rates of substance use and mental disorders, victimisation, extreme family discord and deviant peer associations and maladaptive conflict resolution skills. So a question you could ask is, you know, is our case example of Abdul, so that very first slide that we don't have a lot of information about, but could he be heading that way? So to get back to the area of mental health and youth mental health itself, it's important to acknowledge that having a mental health issue, diagnosis or an episode with within any area of mental health, whether it be seen as mild, moderate or severe, so either in primary, secondary or tertiary, services, can be complex and difficult, particularly during a time of adolescent change, which we know is often a period of growth and movement towards adulthood and increasing independence. And so it really can interrupt the developmental trajectory for a young person. It can also interrupt the system around them, whether it be, employment, educational, social and family relationships. For the purposes of this presentation, we're discussing managing assessment and engagement for those young people with complex presentations. So this can cover those young people with multiple issues in various areas of functioning, whether it be educational issues, housing, family, friends, employment, substance use, refugee status, gender identity, and so on. The other area that must be considered in this area of complexity is the question of risk. Risk is obviously an important consideration and usually part of any mental health assessment. Again, risk does not have just a narrow definition. It can be risk in terms of suicidal ideation and attempts such as self-harm, but also risks associated with vulnerability, for example, to abuse or homelessness. Just having a mental health issue can place a young person at higher risk of not achieving their potential. So again, there's really many complicating factors to consider. Okay, so we've discussed the complexity of defining complexity. So what does this mean in terms of mental health clinical practice and assessment and engagement, particularly with young people? So there can be multiple needs in any clinical presentation, which can be very challenging for any clinician to understand and address. As well, it is a challenge for those young people who may have a range of mental ill health issues or diagnoses, covering the broad sort of diagnostic areas of psychosis, depression, anxiety, and personality. We often associate complexity with severity. However, it is important to keep in mind that a young person can have a mild or moderate diagnosis, however, may be complex in terms of many of the other areas of their life, such as what we've already mentioned. So for our purposes, we could see this as both clinical complexity, psychological and functional complexity. So firstly, it seems important to gain an understanding of what is happening in a young person's life and mental state. This is where a comprehensive assessment comes in. Within early psychosis programs, we've said things such that, like, an assessment is the ongoing process of gaining sufficient information from a young person presenting with possible psychotic symptoms to enable a diagnosis, so guide treatment planning, facilitate the development of a therapeutic alliance, and enable etiological case formulation. However, this is not specific to early psychosis work. It applies to all mental health assessments and is usually standard practice to define an assessment as a biopsychosocial assessment covering these areas. So we will come back to this further shortly. However, really something to keep in mind and that's quite important is that the foundation of assessment is about engaging young people and also their family, friends or any significant others. So what do we mean by psychosocial assessment? So basically it covers the biological, physical, psychological and social assessment of a young person. It's also an ongoing and continuous process and a way to negotiate treatment and support. And a thorough assessment allows clinical staff to construct etiological case formulation. So that means sort of causes really, that can then guide priorities for treatment and intervention. So case formulation is the process where you have a set of hypotheses and can be generated about the etiology of an individual's presenting symptoms and guide specific interventions. For young people, a biological biopsychosocial assessment usually covers the following areas. And I've listed some of the principles there, but a full medical biological evaluation, so physical health. In terms of psychosocial evaluation, it's interesting, Headspace actually lists 10 domains for this, and that includes home and environment, education and employment, activities, alcohol and other drugs, relationships and sexuality, conduct difficulties and risk-taking, anxiety, eating, depression and suicide, psychosis and mania. So whatever form or way you as a clinician perform an assessment, you need to undertake this comprehensive approach to understand at that point in time what is happening in a young person's life and why you are seeing them at that time. So a good question to often ask yourself is, why now? So as we will discuss further, any assessment will require good engagement. So conducting a mental state and risk assessment are only one part of the process. And as you can see there on the slide, listed are other areas you need to be mindful of. So as you can see in summarising assessment, there are a range of principles that support the process. The Victorian Government has listed a range of mental health principles that guide the provision of services. And they're contained in the sort of Mental Health Act 2014 that really guide these service provisions. So if you read them, as shown on the slide, they provide a framework for assessment and overall service provision. If we drill down to clinical practice, then the following slides will show the principles that should be applied when assessing young people. And we can divide them under four main headings of communication, collateral, collaborative, and current. So we'll look at these in each of these following slides. So here we are. In terms of assessment requires best communication or interpersonal skills. So really the sorts of things we're talking about there is flexibility in approach, having some warmth. I think particularly empathy is an important concept, and to be able to show this. Very active listening. So having a non-judgmental attitude, being collaborative, being very emotionally attuned to a young person, and certainly having a knowledge of developmental and life stages. Clinician attitude is important and influential in the assessment process, but is needing to be very respectful and non-judgmental. Obtaining as much information from a range of sources, which you can then sort of be verified by others and or the young person, will help with gain as full a picture as possible. You can see here what may be covered in current and collaborative approaches. We could continue this list of principles of assessment. However, what is being highlighted is that they speak to how engagement is a very important part of the process in any assessment or work. For those young people who have complex presentation, it is of particular importance and requires at times to think on your feet as to the best way to manage. So really there's no golden rules, but certainly an understanding of engagement and best approaches will help. Okay, so let's look at engagement. There can be different meanings. For instance, in Western Australia, they have discussed engagement as their sort of a key principle that underpins their 10-year strategic policy mental health 2020 document, which is called Making It Personal and Everybody's Business. And they say that engagement means that people with mental health problems and/or mental illness, that their families and carers are engaged as genuine partners in advising and leading mental health developments at both an individual, community and service system level across Western Australia. I really like this quote from the Centre for Advancing Health in Washington, and I think they make a very good point. So engagement is not synonymous with compliance. Compliance means an individual obeys a directive from the healthcare provider, whereas we're talking about engagement being a much more active process where a young person is engaged with the clinician or the service really through a process which harmonises the information and professional advice with their own needs and preferences and abilities in order to prevent, manage and hopefully resolve mental health issues or diseases. Okay, the other issue that's important to think about in terms of engagement is that it can fluctuate, and it can be quite an up and down process. It can fluctuate during episodes of care, or it might be that young people might not engage initially, so some may disengage as their functioning or their symptoms improve, and others just might not disengage initially, or else disengage after initial treatment. Each young person's situation is unique, and engagement reasons can be varied. So far we've looked at complexity and comorbidities, assessment principles and engagement, and understanding some of the barriers to engagement can help with understanding how best to engage. So there really is a lot of information that discusses barriers that range from, as you can see there, stigma, the seeking help, difficulty seeking help, not being a youth-friendly service, the nature of the mental health issue or disorder can impact, substance use, past poor interactions with mental health services, past trauma experiences, and challenging behaviours. To those barriers such as practical considerations of timing, ability to attend, having the money to get around, housing issues, transport, and other priorities such as work or school, physical health or medication side effects. I'm sure you could come up with an extensive list yourself. If you think back to Abdul, our initial slide, how would you go about assessing and engaging with him? He's potentially many difficulties, so the key would be to find what you can engage with him about during your initial assessment. So any engagement with a young person requires an understanding of their developmental stage and needs, which may not always meet clinical service staff expectations or priorities. As I'm sure you're aware, the age range for youth of 16 to 25 years or 12 to 25 covers quite a broad time frame and range of developmental changes that are occurring for a young person. So basically it is a time of increasing independence, finding their way into the adult world, decision making, socialising with peers, finishing school and obtaining work, romantic relationships, looking at things like accommodation and finances. So basically a lot of challenges to face even without mental health or other issues facing the young person. Okay, so let's get practical. So interventions to foster engagement with young people who are presenting as clinically complex or difficult to engage are really comparable to those commonly used with all young people attending mental health services. So these include providing information, supporting help-seeking attempts, supporting the young person's family and other supports, and fostering a strong therapeutic alliance on which you can then work together and work on interventions. However, as that slide shows, it is the intensity and manner in which these interventions are delivered that sets apart the interventions, particularly for complex presentations. And so what we'll now look at in a couple of the next following slides are some of the tips that relate to this. So tips for engaging young people when it seems difficult are: one of the first things to do is to think about and find out why. So these could be things like previous experiences that may be impacting on them. You need to also read any notes you have, if there's any previous file notes, to get those and read them. Think about any socio or cultural issues. Ask friends or family. Think about whether the impact of the illness, and that could be a barrier. You also need to use your communication skills. So like what we've said, you need to have respect, empathy, active listening. You need to clarify and be very calm. Ask open-ended questions and also be reassuring. You need to have a positive, hopeful attitude. All the time you're building on working on the relationship. So So that is the foundation for all work. You need to be very trustworthy and for that to come through and be genuine. You also can ask the young person what is their theory as to why they're being seen or what they believe their issues are, or think about the best way to ask that. So really you're looking at what is their explanatory model. You can also start with what the young person says is most important to them. So there you're aiming to collaborate on some common goals that can meet their wants, needs or values. Think about everything from their perspective and show you understand by putting it into words. Consider seeing them in a setting that suits them best. So, this might be at home or in a cafe or outdoors. So you might need to have a team, or you can be able to go out and see a young person in an environment that is, suits them, or else in a particularly youth-friendly space. Transparency is also another important feature of engagement. You need to explain everything you are doing and why, including the rationale for questions, your role, appointments, procedures and expectations. The other thing is don't give up too easily, persevere and be consistent. So, it can take some time to maybe engage young people. You need to continue to keep trying, even if they're resistant or reluctant. So that might involve repeated, structured home visits and cold calls, phone calls, writing letters or text messages, attempting home visits or phone calls at a time when the young person is likely to be home, leaving a message or a note at home, or business card leave one each week can cover a few weeks. So you might do that over a few weeks and might encourage a young person to contact you. You need to be flexible and adaptive. Consider what's important right then and there. If the risks are too high, you obviously may need to be more assertive. Utilise family or friends. Ask them about the young person, their lives. See if they can help you engage. Get as much information as possible. Understand and know about all the services that may already be involved. See if you can get permission to talk to them. Can they help with engagement? Can you see them maybe at another service? Coordinate meetings with services so that everyone knows and understands the issues and roles, and come up with some creative suggestions about engaging. So look, I'd now like to go back to James, who we did present on the second slide, which was, if you can recall, that was all a huge long list of possible diagnoses that he'd received and comments over the time of where he'd been seen. So James was the one, a referral. He had already had several inpatient unit admissions. So most clinicians at some point in time will come across a young person that will be complex and difficult to engage with. There can be so many different scenarios. Too unwell, not wanting to be seen, not wanting to talk, being angry, believing there's no need. As I said, they're not unwell, or they just don't think they need to see anyone. Or sometimes it can be that they just don't feel safe enough. So this is why your clinical judgment and response at the times are important, and gaining as much information that you can is crucial to help with this. You also do not need to do it all on your own. A team is important for consulting with, getting ideas of what to do, possibly having 2 people involved, also separating out roles on the team. So looking at some clinical examples, if we think back to James, how was he assessed, engaged and treated? Apart from his multiple diagnoses, what did he and his family need? So using our assessment headings of communication, collateral, collaborative and current, how can we think about engage and plan for work with James and his family? James came into the service after discharge from private hospital after suicidal intent and self-harm and displaying psychotic symptoms. His mother wanted answers and help and was at her wit's end, really, to know how to manage him. So the first step was to gain as much information about his story from himself and his mother, plus look at past mental health notes, so gaining collateral. And what became evident at assessment was that while psychotic symptoms were, such as auditory hallucinations, were disturbing him, there were multiple other factors that were impacting on James, causing distress to all. Briefly, his father was away for weeks at a time in the Western Australian mining industry. The mother felt very isolated and unsupported. James had no friends and was really attached to his mother, almost like a limpet. He copied her dress, her mannerisms. He knew everything that was happening in her life, but at the same time he was also quite arrogant and demeaning to his mother and to his sister. He was quite an intelligent young man, yet he had missed a lot of school, and the school were very reluctant to have him back due to his behaviour and his attitudes, and also they were very worried about his mental health and the risks involved with that. James also tended to have a superior attitude to others, believing he also knew how to treat himself best. He also had very high blood pressure and was overweight. So this was not a young person or family that was going to engage easily or necessarily follow a recommended treatment plan. They were also in crisis themselves and could not wait long for the service to respond, or James would be back in hospital again. So the first assessment interview was crucial to understand the range of mental health issues, but also the family stresses and dynamics at play. So while James and his mother easily attended that first session, it became apparent that to continue to engage him, that a case manager alone was not going to be enough. It really needed a team approach. So this included psychiatrist, case manager, family worker, and clinician to provide what we call stop therapy. So that is therapy for systematic treatment of persistent psychosis, plus a dietitian consultation. The best way to engage James and his family was also for them to feel, and also not feel but provide, that they were receiving expert assistance and so were special in this way. This was something that was very important to them. If there was any chance of recovery, they needed this expertise from the range of professionals. The other factor was that at that time James wanted to return to school but found his psychotic symptoms distressing and wanted these fixed as they interfered with his life far too much. So this was really looking at engagement and focus for help. It seemed the best way to engage with his family to have a very structured approach. So to state clearly what could be offered and by who, offer regular appointments and full clarity at the commencement of treatment as to the explanation of who and what was involved in the treatment approach. It also had to start with what James and his mother were saying were the most important areas they wanted help with. So we do not have time to go into all the details of this case and what was provided over several months. But I can just highlight here how we did approach it quickly so you've got a better understanding. So, as you can see, there was active work by the case manager. So really overall coordination and re-engaging James back at school. So really several meetings with school. And that was really to explain his mental state, also to come up with a timetable to move from part-time to full-time school, homework and study, agreement for all of this with James and his mother. His mother was also very upset and angry with the school, so we needed to work on those things. We also needed to work on getting him there. He could walk to school, but his mother had been driving him frequently. The case manager also looked at developing James's social contacts and work on how to interact in social situations. We use this medical and psychiatrists for review and medication, but for psychoeducation, for reviewing symptoms, for risk monitoring, metabolic monitoring, and team consultation. Family work was also another important feature. Sessions with the mother for debriefing, psychoeducation, and specific ideas on managing his behaviour. So what was illness related and what was not? How could she work on setting some limits with him, but also continue feeling that she could support him? Also some whole of family sessions when the father was back from Western Australia. And also giving them support and managing the situations when James was in crisis. There's also the clinical expertise, so specific interventions for James to manage his psychotic symptoms. So he would continue to engage in therapy, identify triggers, use some of the techniques that were suggested, review and have some adaptation of those, and also a dietitian to help with nutrition and weight loss and to improve his high blood pressure. So while this might sound straightforward, this one case required intensive work, a very coordinated approach, a coordinated team-based approach as well, a respect for the individual and family beliefs and values, and engagement took time. If the treating team had not understood from commencement and acknowledged the distress for all or acknowledged the family need for expertise or specialness and assistance with practical issues, there would have been no engagement or attendance for treatment. So while taking a structured approach, flexibility was required to manage some crisis presentations. James did manage to have his psychotic symptoms resolved, returned to school, and less behavioural issues occurred at home. But he needed ongoing work regarding peer relationships and future goals. It is important to not only consider the complexity of the young person, but the complexity of the service system around them, and that includes the treating team. So there can be disagreements regarding diagnosis, medication, risk, views around negative symptoms, family work, whether that's important or not, case manager role, and treatment approaches. So in order to help young people who you need to maximise and deal with your own possible deficits in the service system. So what you need to do as clinicians is go after the information and research this. Think about what you think will help. You need to try and be creative. So engagement as a team and united as a team is a really crucial factor. So complex presentations can cause a heightened sense of concern by all involved, a sense of being overwhelmed by the issues or despair at how to assist, or sometimes clinicians can panic and become intense and angry and become, I suppose, even angry with themselves, or it can lead to a tendency to revert back to blaming the young person, the family, the service, or think that as a clinician you're not skillful enough. So this is why supervision, team discussion and case presentations, particularly complex ones, to a team of experienced senior staff can prevent this from happening and help share the burden by carrying the concern service-wide. So it is important to understand and acknowledge that and to set that up in whatever service you are in. So remember, as a clinician, you cannot know everything, so use the experience around you. We do not want young people not assisted due to the stress or inactivity of the team around them. Now, Caroline was going to talk to these slides in terms of two other clinical examples. I'll just quickly go through them and just very briefly cover them. So I'll let you read some of that clinical information there. This is about Marco. So you can see, his early history and what he was at 15 years of age and at 16. And the referral. I think the biggest issue in this case scenario is that it highlights some of the issues to do with, I suppose, complexity from a diagnostic standpoint and how you go about considering that in practice. So Marco is an example who clearly needed some treatment and probably needed intensive psychosocial intervention because he had a lot of other difficulties from a very young age. So his mother was the main support person, and really she was doing it on her own. And she had Marco had 4 other younger brothers and sisters that mother had to look after. On the background of that, Mum was feeling very overwhelmed and blamed for all the issues. So it would have been very hard for her. So what the treating team and case manager had to do was work on long-term engagement with him. Because of his history of trauma and the autism diagnosis, it was going to be more difficult to develop rapport with him. He was also very suspicious of services and was hiding from the treating team when they arrived to visit him. So the team discussed at length how they could approach working with this young man. And this is what they came up with. So Marco was already very difficult to engage, and forcing him to go to hospital would not have been helpful in the short term. Although as a team they had to work with a lot of unknowns, and being unable to actually set eyes on him for a few months was very difficult, and something that they were often questioning and discussing and thinking as to which is the best way to manage. But what they aimed to do was to be very predictable and follow a routine. And really, one of the reasons for that was that we know that people with autism generally have a much harder time coping with change or unpredictable circumstances, and so this is very complicated for engagement with him. Part of the engagement was to develop this clear routine and let him know when they would be arriving and when they were leaving. So eventually he decided to walk past the room where the clinician sat with Mum talking. He walked by quickly and she managed to say hello to him. The next time they visited, he had stuck a note on his door saying, "I don't want to see you, please go away." Very understandable. The clinician wrote a note back saying, "Thanks for letting me know how you feel. I'll come back on Thursday at the usual time." And so she didn't give up. She just decided to persevere. Eventually they moved towards him spending increasing amounts of time with him in the house, talking about his interests, and eventually to a full assertive outreach model for intensive psychosocial intervention. They kept the twice-a-week contact at the same time, and eventually Marco took more control and agency in his treatment as his mental health improved. This is our last example before we'll finish the formal presentation and open for questions. But as again, I'll let you read that slide there. But this is about Xavier. So you can read the early history and, what he was doing in terms of his 15 years of age and 18 years, and also what his diagnoses were. So Xavier is an example of a young person again with a lot of complexity in the system around him. Not only were there a lot of services involved, but they were all very concerned about his offending, behavior and level of risk. Xavier was quite well known to police, and at the time of referral there were real concerns about him being at risk of imprisonment. If you see what's written on the slide there, you would start to be concerned about that. One of the main issues in Xavier's case was that due to the multiple services involved, the system was in chaos. He had also just turned 18 and was moving between child, youth, focused services into adult services. And one of the main issues in Xavier's case was that due to the multiple services involved, the system was in chaos. He'd also just turned 18, and as I said, he moved on. So the focus of his engagement and assessment was to get all the services together effectively, really, rather than just working at cross purposes. It meant that the chances of him getting a therapeutic outcome from any or all of the services was improved if we did that, and he was also less distressed and confused about what he should be doing. One-on-one time with Xavier focused initially on practical assistance, reducing his stress and improving his mental health symptoms. Case managers focused on engagement, and whereas the doctor in this particular situation focused more on the medical treatment role. Okay, so I think we have come to the end of our formal presentation. So I'd like to thank you and also hand back to Shona for a moment.
Thanks very much, Heather, for a very comprehensive walk through all the issues of assessment engagement with very complex young people. We hope that you have enjoyed that presentation. Just allow Heather to collect herself for a few moments before we address some questions, and I'll just tell you a bit about a few things that are available through Orygen. So firstly, just a reminder that this webinar will be available via the website soon, once it's been uploaded, and that you will receive a certificate of participation in this webinar shortly, as well as an evaluation. So we would be very grateful if you would complete the evaluation and send it back, because we'd really like your feedback to help us when we're planning further webinars. That email will also contain a link to the recorded webinar if you want, but you can also access it via the website. Okay, so also we have a new online training module available that you might like to check out. That's available via the website. Excuse me. So this is on young people and mental health and technology, which is a very important topic these days. This is a module provided by Professor Michael Carr-Gregg. So I encourage you, if you're interested, to have a look at that. And also, just to let you know that at the moment, the wide range of manuals, therapeutic clinical manuals that Orygen has produced, are available on sale. We're having a spring sale, so they're available now at 40% off. And they're also, you also get those via the website. So have a look there if that's of interest to you. And just to let you know that we have more webinars coming up. So on the 11th of October, Heather is doing another webinar on collaborative work and models of care. And then in November, one of Orygen's psychiatrists, Dr. Chris Davey, is presenting a webinar, latest developments in antidepressant medication use in young people. And then what's probably the last one for this year, on the 1st of December, Professor Andrew Channon is presenting a webinar entitled Prescribing Challenges in Prescribing Challenges in Youth Mental Health Treatment. Okay, so now we might just have a look at some of the questions. I might get Heather to come back and join me. We might see if we can both fit on.
Yeah.
So we've had some questions sent in, and we encourage you to send in any others that you might have at the moment. I'll just sit to the side. Heather can be on there.
Oh, no, you can Okay, we've done it.
All right. Okay, so the first question that came in, Heather, you might see up there on the screen, was about how many times we might persist with a young person who's being avoidant.
Okay, well that's a great question. I don't think there's any set rule for that. This is where your clinical judgment comes in, but also getting as much information as you can. If you think about that clinical example towards the end that I presented in terms of Marco, you know, that was actually took a couple of months before they actually engaged with him, where he would actually talk, and that was, you know, twice weekly home visits. I think the things to keep in mind are really things like how urgent is it? How risky are they? Are you going to actually cause disengagement by continuing to persevere? Like, I know I said perseverance is important, but you really have to still use clinical judgment with that. And I suppose the bottom line is if things are not too risky and not too difficult, and you know, they can sort of be okay for the moment, the bottom line is you want them to come back maybe when things deteriorate. So really, I suppose I'm saying you need to think through it all and use your clinical judgment and weigh up what's best to do in that situation, but maybe go and consult with your team and talk about that.
I mean, I think we, in that example and in other examples I'm aware of, being persistent and perhaps being consistent and regular as well. So
yeah, exactly.
I've certainly heard of examples where clinicians say, right, I'm going to come and see you at Wednesday at 4 o'clock every Wednesday, and they just leave a card, and eventually the young person has engaged.
Yeah,
so it does very much depend on the situation, doesn't it?
Yeah, that's good. Yeah. Good point, Charlotte.
Yeah. Okay, so The second question we have that's come in is about working with shame.
Yeah, that's a great question as well. You know, I mean, we might have different thoughts about this. It would be good to sort of explore that further. I suppose what I would think is, I think you need to put it into words, and this is where sort of your empathy comes in, but I think it would really be the timing of when to do that, you know. But it might not be something you would want to say, you know, straight away, but to really try and find out and think about what is it, you know, that's happening, what would they be feeling shameful about. And, you know, you have to say it in a way that maybe is not specifically about them, but to put it in the context of things like, you know, you can say, you know, I've worked with, you know, I've seen quite a few different young people over time, and, you know, this is what I found with one young person, blah, 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 about, you know, that they were feeling quite ashamed of themselves for these reasons. You know, I'm wondering if this is what might be happening with you. So to put it in that sort of way, I think. And I suppose also to then say that, put in the context that it's not an uncommon type of feeling, and to acknowledge it in that sort of way, and then sort of move on to, you know, these are things that we can cope with and help you with if you would like that.
Yeah, I think I agree with all of that. I guess that some of the shame might be about the stigma of mental illness, and so perhaps providing some psychoeducation about the rates and incidence of mental illness and the sorts of symptoms that people do experience might help the young person if the stigma the shame is a barrier for coming in, might help them to engage.
Yeah, absolutely. That's right. That's what stigma often is, isn't it? You know, and as we said earlier, you know, especially for young people, like they don't necessarily want other young people to know they're coming in. Some do, some are happy. So it's really trying to sort of find out and understand what is the issue for them.
Yeah, exactly. And I think one of the points that you mentioned earlier was the importance of transparency as well. So I think being as open and honest as possible can help as well. So to let people know why you're doing it. And often with young people in particular, they don't know about confidentiality. So they're not aware that, you know, that health professionals are bound by confidentiality and that their information isn't going to be spread. So that can help as well to actually make sure they know the rules and the way people operate health services.
Exactly.
So we asked to say a little bit more about engagement versus compliance.
Okay. Okay, I mean, I suppose, you know, the point with that is, you know, someone can be compliant and engaged. It's more, I suppose, trying to really think about just because, you know, if someone might, okay, they turn up to an appointment to see you, so they're compliant in that way. So if you think about it, all right, they've been asked to come in, they've agreed, they've turned up. Are they actually involved in the treatment, though, with you? Are they engaged with you as a clinician? Are they happy to talk to you? So it's trying to think about, you know, just making that point that just because someone turns up doesn't mean that they're engaged and going along with the process. But, you know, the other side is that, you know, sometimes, and this is what I've found working over the years as well, that it doesn't always need everyone to say and acknowledge that they are compliant either. If you think about sort of medication, this is often an issue that clinicians get very concerned about and ask a lot about with young people, and often say, are you taking your medication? And they want people to sort of acknowledge and say, yes, they are, as well as say, oh, yes, I am very unwell. You don't need people to actually do that. As long as maybe they are taking their medication, they don't have to tell you and say they are, you know, have got mental ill health or do it in that sort of way. So I'm not sure if that answers fully the question.
Yeah, it's like a question about how to improve compliance in the education setting, I guess. And that gets back to engagement, I think.
Yeah, that's what I think as well. I think
it's to try and get in touch with young people, understand what it is they're wanting, and try to match the young person's values, or help them to recognise what they value about what they're education is going to provide for them.
Yeah.
Yeah.
Okay.
It's resistant.
Can you suggest approaches for engaging parents, who are resistant to therapies and treatments? Well, it's the same sort of engagement principles apply, really. I suppose it's more like, what do you want them to be involved in and why? Are you asking too much of them? Do you want them to be involved in therapy, or do you want them to be available to provide support and help, to the young person? So it's the same principles. You need to understand what's happening for them. What do they want? How can they, I suppose, what strengths and weaknesses and barriers are there for them? So you sort of need to maybe do a sort of draw a diagram for yourself about everyone in the family and what are their sort of wants and needs and, their values, and what's the aim of treatment. Is it to have a sort of, family all working together and supporting each other? Is it sort of just psychoeducation and support that's needed, or is it more family therapy? But you would still use all the same sort of engagement techniques that we've discussed so far.
Yeah, absolutely. I think it's very important that parents understand what's being offered. So I'm not sure if the question's about parents who are not keen on their young person receiving treatment. If that's the case, I think then it's the clinician's job to explain as clearly as possible what the how the young person's presenting problems are understood and what the evidence-based treatments for that condition are, and hopefully get the parents on board with that.
And as being open and honest with the parents about that you do need their involvement, because I think this question might relate to, I suppose, a situation where it's easy to think, all right, it's like, well, and parents can do this where they think, look, it's a young person, you just need to fix them up. I don't really need to be involved. So, you as a clinician or whatever profession you're in need to sort of explain and also understand that often if a young person gets unwell, that this can be very confronting and distressing for parents and family members themselves, and it can be a crisis for them, and that they need psychoeducation, they need understanding, and they need a lot of support. If we think about those clinical examples we talked about, the mother for James was, beside herself with having to deal with him, do with it by herself all the time. She didn't have a husband who was around. She was overwhelmed, and she really needed a lot of encouragement and support to know that she could manage this. And that's where you, as a treating team, can come in and help with that.
I'm wondering if that might be a place to start to finish, or there's perhaps, do you want to look at the one more question about complex young people in crisis? Yeah, sure. Look, I suppose it's the same as you deal with any young person in crisis, really. I suppose it's trying to think of you would need to assess risk, yes.
And what actually is the crisis about? How immediate is it? What are the risk issues? You need to look at sort of what we call dynamic and static factors. So, there's static factors are things that have happened in the past that you know about. So, when you talk about, say, history, has this young person hurt themselves in the past or become very aggressive or angry in the past? So they're sort of static factors. But what you need to look at is what are the dynamic, factors and what can you change now? And obviously, if someone has a lot of complexity, so they might have a lot of, issues with family conflict or substance use, accommodation, all those things. So I suppose what you're going to be looking at is what may be impacted on, and the complexity of having a number of different, problems can really add to it. So you need to look at what are the protective factors that you may be able to bring in to help look at engaging and sort of, I suppose, resolving the crisis. Yeah. And, if it's particularly angry or aggressive young man, how can you try and, de-escalate that type of situation?
Great.
Okay.
Thank you very much, Heather. I think we've come to the end of our time for this webinar today. So I'd like to thank everyone for participating, for attending the webinar today. And we'll see you next time. And thanks to Heather again.
Thank you. Thanks, everyone.